just a sec, George. I'll just give you some introductory remarks. Some of you may have heard this before, and a lot of it's the same. I've updated a little bit, but there's a couple of themes in antibiotic prescribing that are important to us that we have to keep in our minds when I still write prescriptions, but when we create a prescription. And those are Clostridium difficile diarrhea. And the other really important theme is the increasingly drug-resistant bacteria that are present really around the world, but certainly in the United States as well. Locally, C. difficile infection or C. difficile diarrhea, Montana is split up into regions. North central Montana is called Region 2, centered around Cascade County. Yellowstone County in Billings has the highest rate of C. difficile in the state, and we're number 2. So we have a lot of C. difficile here, more than I think we should in a state with our population. And then the other issue was increasingly drug-resistant bacteria. It's certainly a feature of our hospitals, not so much our little Great Falls Clinic Medical Center, but our local hospital at Benefice. We see an increasing number of particularly urinary tract infections where there are so many drugs resistant that there are no oral options for treatment, and the patient has to have an IV line just to have a bladder infection treated. So these are real things, not theoretical things that you might read about that are happening in Los Angeles or something. These are real things that happen in our community. Lots of C. difficile and a much more increasingly drug-resistant things in the community. So when I see that stuff, I'd like to educate as much as I can about my perspective on how to prescribe antibiotics for common illnesses. The themes in the literature, recently in the New England Journal, there's a whole paper describing a region that tried to do this theme that's called right drug, right dose, and right duration, with a lot of emphasis on shortening the duration of antibiotic use for some common illnesses that we otherwise would prescribe maybe 10 days for a number of different things. There was never really a lot of data that showed us what duration is correct, and people are really focusing on that now in order to reduce C. difficile and reduce these incidence of drug-resistant bacteria. So we can go on to the first one. I'm just going to go through a couple of, and there's a handout too that summarizes in one sheet all of the things that we're going to talk about. I'm starting with the outpatient setting. You have to go a little far into the staples portion one. There's
The very back page.
it might be the very back page. The first part of this, and we can get to this, we run through this and there's not a lot of questions or controversy or whatever. I can show you the first part of that handout has to do with hospital drug decision making. So these choices are based on what's called our local antibiogram. And in there is the 2013 antibiogram, but there is a 2014 now, which did not have much significant difference. The antibiogram is available on the Benefice intranet, or I can get you one in your offices if you like to use those. But basically, this is empiric antibiotic selection, meaning that you'll either not have a culture to look at or the culture is pending. So we have to make an informed decision of what antibiotic we're going to start. So I started with uncomplicated pyelonephritis. That simply means the patient doesn't have a lot of nausea, vomiting, or pain, and they're not going to be admitted to the hospital. They're going to be managed as an outpatient. If they have no evidence of penicillin allergy, the most common organism is E. coli, and locally first-generation cephalosporins have very high susceptibility rates. So the empiric drug of choice there is Keflex. And then these are all adult doses. Oh, I don't see pediatricians here. I think. Oh, adult doses, 1 gram PO twice a day. And so if you have a serious penicillin allergy, which is defined as anaphylaxis, it basically means you have a history of receiving a penicillin or a cephalosporin, and generally within 30 minutes to an hour you had an IgE-mediated reaction, which is low blood pressure, tachycardia, change in mental status. We all know what anaphylaxis is. We have to avoid sometimes if someone had a late onset rash. A lot of these, we'll be discussing that over and over again. That's someone who might not be able to get a penicillin but could get a cephalosporin. But in this case, if someone has a fully penicillin cephalosporin allergy, they would get Bactrim. And then a final one there is if they couldn't get any penicillin, cephalosporin, or sulfa, we save the fluoroquinolones for the end. I think a lot of the prescribing practices in Great Falls put fluoroquinolone up at number 1, but we really don't need to be doing that. Remember, save anything that can treat Pseudomonas for last. We shouldn't really be giving out fluoroquinolones unless we need to treat Pseudomonas. So what's happening as far as nationwide, as far as loss of ability to treat some of these bacterial infections, are primarily focused on the gram-negative rods, and particularly Pseudomonas. One thing I haven't seen in the local community, and I don't really want to see, is a fully untreatable organism, which is primarily Pseudomonas in larger metropolitan areas. So it's good for us to be in the practice, though, of not using an antibiotic that we might need for a more serious infection. I would generally say with pyelonephritis, or clinically, if you think that's what it is, we would submit a urine culture. And then duration is different, a little bit longer for men than it is for women, but 7 days of treatment for female, 10 for a male. Thank you. And then non-purulent cellulitis is the new term. We call a lot of things cellulitis, and we'll go over a few different nuances here, but non-purulent is generally the big red leg that the person comes in with. Typically a male. The redness ascends up over the foot and on, sometimes circumferentially around the lower leg and generally up the medial thigh. There's not an open wound to culture. It's just a scalded looking skin. We've all seen that. That's now called non-purulent cellulitis. Culture there says no, but if you are thinking about that patient as a hospitalization, then you do put blood cultures ×2 on the orders. We do sometimes find the organism in the blood. Almost all of that is beta hemolytic streptococci, particularly group A Streptococcus pyogenes. But not all of it. Probably 85–90% of these typical non-purulent cellulitis are beta hemolytic streptococci. The remainder is Staph aureus, usually methicillin susceptible. And then the diabetic patient, occasionally you see cellulitis proven in research studies to be polymicrobic. So the choices generally are broader than just penicillin BK, for instance. Most of the time you'd be right with penicillin, but sometimes not, so the initial choices are a little broader. So I would say absolutely perfect for that condition, potentially keeping the patient out of the hospital. If you could get them off work with the leg elevated and on a good oral antibiotic, we might be able to avoid hospitalization. So that's Augmentin XR, 2 grams POBID. So penicillin allergy, rash, and hives only, able to take a cephalosporin, that becomes Keflex. And then anaphylaxis to penicillin, the last choice there is clindamycin, 300 QID.
If the patient was coming from a group home or a nursing home, would your choices change?
There's really, it's a good, we're going to talk about MRSA in a slightly different setting for skin and soft tissue infection, but if it is non-purulent cellulitis, no venous stasis ulcer, no boil, MRSA is not being found. The research there is to take the leading edge. These often have they're circumferential up the lower leg, but they have some sort of a leading edge you always see. So in research settings, to determine the microbiology, they do punch biopsies of that leading edge for culture. MRSA has not been found. So for this condition, now there's another one we'll go on called purulent cellulitis, where they're almost all MRSA. So there is a distinguishing feature based on the physical exam.
Great. As far as getting the culture, so a person, if we're going to get a culture and we're starting somebody on augmentin, wouldn't you want them symptomatic before you bother getting the culture?
Like fever?
Fever, yeah.
And of course the physical exam would be
Maybe you'd have that, but you'd want them to be symptomatic too before you got blood cultures ×2.
true, although surveillance blood cultures for a hospital admission for the significant cellulitis of the lower extremity, I get them. Yeah. And then sometimes what that really is helpful for is if you get one or both of them that grow group A strep, or in this community we see group C, group G. That gives you the confidence to say all they need is penicillin. So here's culture no. Duration is 7 days. so that we don't really need to be running for 14 or 21, those kind of things. Thank you. So then we have I don't know if we like to talk about it that much, but we have one of the highest rates of methamphetamine use in the state. It's just, this community is like a magnet for those people. They're all here. There's some in Billings, Missoula, but there's a lot here. So you guys are seeing a lot of skin abscesses. The patients don't like to talk about that much. Some are more open, many are not. But tiny skin boils in the region of the venous supply is IV drug use. And I've stopped thinking, oh my God, I've never done that. I don't know what to talk about. It is. It's just not something that they're very forthcoming about. These are often a mixture of beta hemolytic streptococci and MRSA. And sometimes they're large enough that they need lanced and cultured. They'll have a purulent coming to a head, so to speak, and that does need opened up and drained as part of the therapy, and that gives you a chance to get a culture. Anytime we get a culture result, that allows us to de-escalate the antibiotic. But this is a community where once you write the prescription, they may not come back for follow-up. You might not see them again, but still the culture data is useful to us because it expands the epidemiology of what we know in the community. So no penicillin allergy, there's going to be Keflex, and then the Bactrim BS is specifically for MRSA coverage. If that person was fully anaphylactic to penicillins and cephalosporins, you'd have clindamycin and Bactrim, and the reason for that is Bactrim does not cover beta hemolytic streptococci, so you still need a drug for that class of organisms, so that's the clindamycin. If they were sulfa-allergic, we came up with Keflex and doxycycline. The doxy there is the MRSA drug, and there the duration is 7 days. That can be a little complicated because it's 2 antibiotics, and it's potentially someone where we need to ask, I'm going to send this to wherever you have the funds to purchase it, that kind of thing. So it's a difficult community to work with, but they have a lot of healthcare needs. Okay. And then this is not associated with IBDU to the best of our knowledge. I mean, we're all going to meet people who have boils, and maybe in places where you probably could not eject, like without a mirror or something. So you're going to see boils also. And a lot of these are community onset MRSA. That is a real big issue nationwide and here, often called spider bites. I would bet that almost everything in our career that we call a spider bite is MRSA. We just didn't know it until culture studies were being done. If you wake up in the morning and there's a spider feeding on your foot, that's a spider bite. But otherwise, what public and what providers call spider bites are almost all MRSA. So the empiric treatment is directed at that. Bactrim is the main drug. Doxycycline if you're sulfa-allergic. If you do open these up and drain them, culture them. It adds to our ability to say what they are, creates what we call an antibiogram. If we don't do any cultures, we don't have any data to decide what to do empirically. So cultures may not, they have a societal benefit even when you can't really see that it's necessary for the individual patient. And duration of therapy is 7 days. Thank you. So dental infection, it's not uncommon. Someone comes in to see you because they have a dental abscess and swollen face or under the jaw, and it's going to be quite a while before they can get to see a dentist. The dentist is going to want them on antibiotics before they do any kind of procedure. These are mixed infections with aerobic and anaerobic organisms in the mouth. So no penicillin allergy. Augmentin in the standard 875 milligrams is correct. If you just have a hive-only penicillin allergy, cefuroxime is the choice. And a fully anaphylactic clindamycin. There's really nothing to culture there. I've tried to work with the lab for complicated infections. If there's an infection that comes out through the submandibular space and is draining pus, that's probably going to go to the hospital anyway, and I will try to culture that. Intraoral infections that come out through the face or under the jaw, you have to talk to the lab when you submit the culture, because otherwise in a day or two it's going to say usual oral flora, and you haven't gotten what you wanted. So if you tell them that they need to work up what's there, that helps. treatment is generally 7 days, and we try to get them in to see the dentist at that time. Okay. Sinusitis, that's common, and I realize it's difficult to diagnose. It's difficult for me to diagnose it. No one's going to really want a CAT scan for every sinus infection that they have. There's also rhinitis, which is the leftover of a viral infection where there's a little purulent secretion at the end of a cold. They still don't feel well. But before you even prescribe any of this stuff, we just have to be sure that they need it. Because there is a lot of viral infection, of course, that you see. Some of the symptoms that I might look for are localized pain. Sometimes the sinus infection is localized to a specific area. The person will say, right over my right cheek is exactly where the discomfort is, and you get the history that they had a viral URI recently. That would make sense. Localized headache. There's also maxillary sinusitis causes pain locally in the hard palate. So there's some things to look for, but I realize that it is not always that easy to know specifically that sinusitis is present. Another thing that I sometimes think is useful is the length of time with symptoms. If this started out as a viral URI, you should be able to get to day 4, 5, 6 and be better. If the problem just keeps going on and on and on, they have 14 days of symptoms, unilateral purulent drainage from the nose. Now we're starting to believe it a little bit more. But there is a lot of crossover clinically between what is a viral rhinosinusitis and what is a bacterial sinusitis. Time and symptoms going on and on and on tends more to be bacterial. At that point, the patient probably doesn't want something. If they're coming in for antibiotics on day 3 of nasal congestion and discomfort, I can tell you that's not bacterial sinusitis. There's just no reason for them to leave the office with an antibiotic prescription. That's a big theme in the literature, and we all see this as the patient wants to leave the interaction with a prescription. But that doesn't have to be an antibiotic. It can be your sage advice on what they have. Mucinex is not a prescription, but it's useful. I don't know, Jim believes in that. Yep.
Yes, I do.
Yeah. So it's a difficult issue. The consumer has been trained over the years that the interaction with the physician will result in an antibiotic prescription. That's coming to an end. It has to. Too many people. Ask any consumer who got C. difficile diarrhea that came back 3 or 4 times. They'll never ask for an antibiotic again. They'll be dying before they get an antibiotic again. But we don't want that experience to be the thing that changes what they want. But we as providers will just have to emphasize going forward what are the risks of an antibiotic. We haven't been doing that traditionally. And again, those risks are mainly C. difficile. And in the future, when you do have a serious infection, we won't have an antibiotic that we can use to treat you. The more informed consumer will think about those things. If it is a viral infection, they'll pass on taking an unnecessary antibiotic. Enough of that. Okay. So, no penicillin allergy. Augmentin is perfect therapy for sinusitis. Hives only would be cefuroxime. And then anaphylaxis to penicillins and cephalosporins is sulfa or Bactrim. And then lastly, I would pull out clindamycin only if they could not get penicillin, cephalosporin, or sulfas, which is kind of last in the line. There's really nothing to culture. I wouldn't put a swab up the nostril. Does anybody do that? No.
Any indication for quinolone ever?
It's not on there because of the Pseudomonas issue. All the new literature says if you are not treating Pseudomonas, and here we don't have a culture proof of it, or there's no reason to believe that it's Pseudomonas, the fluoroquinolones stay behind. And duration of 7 days. So a lot of times I see people, I don't know, maybe I'm seeing them for something else, and I'm just taking their history, and they just got finished with antibiotics, and they say, I took them for 21 days for sinusitis. I've probably seen them for C. difficile. So typical post-viral infection, bacterial maxillary sinusitis, 1 week.
Well, that's interesting because I remember in my training at one point, antibiotic or penetration in the sinus, and so if you had a socked-in sinus, that it might take longer. And obviously, it's changed.
It's being challenged.
And that's good.
So Mucinex definitely, the reason that there wasn't good penetration was there's just so much congestion and edema of the tissues. We want to try to reverse that. There's another, I guess I could call it Afrin, but it has another more, there's just other ways to kind of get that mucosa to shrink and get a better blood supply. Temporary use. But yeah, that's how I would have been trained too, but that is just all being challenged. Yep. Okay. So here's pneumonia that you think is not viral pneumonia. Potentially is a bacterial community-acquired pneumonia, but the person is not so sick that you're going to admit him to the hospital. You're going to try to treat him as an outpatient. One really quick and easy test that just helps if you're on the fence is a portable O2 sat. If they're 99%, you're doing fine. Anybody that's below where they should be, 90, 92 for instance, that's maybe someone that's not going to do well as an outpatient. It's just a quick and dirty hospital, no hospital type thing. You've already finished the exam and you're the rails and they have the cough and the pleuritic pain. You're set that pneumonia is present. But sometimes hospital yes or no is a little harder. Tachypnea, dyspnea, those are pretty much, they're going to go in the hospital. But an O2 sat is helpful. These are almost always Streptococcus pneumoniae in the outpatient setting. Community-acquired pneumonia was a term derived to describe pneumococcal pneumonia. There's a few other causes of community-acquired pneumonia. Some are viruses, some is Haemophilus influenzae, but generally when we say community-acquired pneumonia, we should be thinking pneumococcus. And so some choices for no penicillin allergy. Now this is a little bit different because we also have to think about atypical pathogens, which are called co-pathogens that come along with pneumococcus. They're hard to find, but they're basically chlamydias, mycoplasmas, and legionella. And they may or may not have, different parts of the country have different prevalence of these co-pathogens. But with the use of the new respiratory PCR panel, locally we do have chlamydia pneumoniae as a co-pathogen. So these drug choices are just looking at pneumococcus plus the possibility of these atypical bugs. So both doxycycline and clarithromycin are good pneumococcal agents. And this is in someone who's not going into the hospital and you can see them for follow-up. But if they're allergic to either tetracyclines or macrolides, then it's clear that a fluoroquinolone would come in, regardless of the Pseudomonas issues I've been talking about. I do like cultures of sputum, and I think that clinically, if a person has pneumonia, they're productive. There are some that are just total dry cough, but I would try to get a culture of sputum. And then this is, again, someone that's not all that ill, so we're not talking about really long-term antibiotics. 7 days is what I see there. There is some literature emerging, I don't know that it's definitely relevant to our area, where the macrolide clarithromycin, similar, azithromycin is an azolide, but I think of that as macrolide. Something called macrolide monotherapy failures in pneumococcus. So we would never do that in a hospitalized patient. They would not go to the hospital and just get IV Zithromax. They would get ceftriaxone as well. But in the outpatient setting, there's not been that much known about or reported of macrolide monotherapy failures. So these are two good drugs to think about for the person that's not going to be hospitalized.
Do you have an IC chart? You know, there's a whole list of all the different doxycyclines. Do you have a preference?
Let's see. I'm trying to.
Hycolate and.
I think that's what we use. I'm writing them, and then I'm standing there at the computer with my nurse and trying to say that one. But
Yeah.
It's,
Yeah, monohydrate, yeah.
It's Hycolate that I'm pretty much
Hycolate is one, yeah.
which produces a capsule, as I recall. There is doxycycline tablets as well. I'm not sure that there's a real literature, evidence-based difference between the products, but I've been using Hycolate.
There's a cost difference.
There is a cost difference too. One of the generic doxycyclines is really expensive. The
high clay.
The high, oh, that's probably why the specialist uses it. Yeah. I don't know that there's you couldn't find a published literature that says this one works better than that one. So if it went down in cost, we could find out which one was better. Okay, strep pharyngitis. One thing on just pharyngitis in general, there have been some very good recent studies with the use of PCR that just helps the provider understand how much pharyngitis is virus. And there's probably nobody's surprised. Most of it. Some of the studies look at 98% of episodes of pharyngitis in a research study where carefully collected pharyngeal specimens treated with a PCR panel. 98% of it was virus. Very, very little of it was beta hemolytic streptococci. And then other than virus and beta hemolytic strep, almost nothing. There's one entity sometimes when you take a throat culture and you find Staph aureus. That is because the nasopharynx is one continuous surface. So people are colonized in their nose with Staph aureus, but you can find it in the pharynx. But that's not the cause of their pharyngitis. That's just that people that are colonized with Staph aureus are colonized in their throat as well. And so that we don't want to misinterpret that as the cause of pharyngitis. It's probably still virus. About 30% of Caucasians carry Staph aureus in the nose. There's not so much data for other folks, but do we just know in European Caucasian studies that 30% carry Staph aureus? It's not a disease. Those folks are just called immunotolerant. 2/3 of the world are immunointolerant, and 1/3 are immunotolerant. Another way of looking at that is if you use mupirocin to remove that carriage before a surgery, 2 weeks later it's back. They're just completely tolerant of having Staph aureus on the skin. It's not a disease. It's a variation of normal. So again, most pharyngitis, and that's not like 3/4, that's near 100% of pharyngitis is virus. So when I use these antibiotics, you've already done something that proved to yourself that strep is present, and that's usually the quick test or the, what do we have?
DNA.
DNA test. Oh, good, that's right, we do. Yep. So let's assume you're satisfied that beta hemolytic strep are the cause of the pharyngitis. Penicillin has never failed. It's still as good as it was in the 1950s, which is really interesting. I could talk about this all day long, so just bring me in for every now and then. But certain organisms adapt and change constantly, add and subtract from their molecular genome all sorts of antibiotic-resistant genes back and forth constantly. Gram-negative rods do that a lot. But beta hemolytic streptococci are not interested in anyone else's genes. They will reject them. They just stay stable as far as their antibiotic susceptibilities over time. It's just a little interesting thing about them. Penicillin still works. I would use 500 QID. So if you have hives only to penicillin, Keflex is a good choice. Fully anaphylactic to penicillins and cephalosporins, clindamycin comes up there. Instead of culture, I put rapid test. And then here's something that just, again, has never changed from the days that we first studied group-based strep pharyngitis right after World War II to now. It requires 10 days of therapy so that you do not see community outbreaks of rheumatic fever and post-streptococcal glomerulonephritis. So 10 days is important. What don't you see on there?
Is there ever an indication for an atypical or a Haemophilus pharyngitis?
There is not. So what we don't see on there is azithromycin. And this is based on these fairly modern, within the last 5-year PCR studies, carefully conducted in children and adults, where we just did not find in the pharynx things like chlamydia, pneumonia, mycoplasma, etc. Haemophilus, I think, is just unheard of. So,
Right. I had a question about.
There you are.
So nasal swabs for pre-operative,
Yeah.
when it grows out MRSA and then we give them vague, that's prophylactic, obviously.
Yep.
What's the reason behind that? Because I've always just thought it was kind of overkill. Is there like a higher incidence of MRSA infections with people with nasal swab of MRSA, or what's the deal?
Exactly. The link is most of the studies that were done to correlate nasal colonization with skin colonization are not things that we can reproduce efficiently. But so in order to show that there was a correlation between total body MRSA colonization and the nose, swabs were taken from nose, lower maxilla, inguinal creases, perianal, vaginal, interdigital spaces between the toes. And these were volunteer patients that were going to have elective surgery. And we were able to show that the nose was probably the best place to find MRSA in these colonized patients, so that we didn't have to do all those body sites over and over again to find it. But if you can find MRSA in the nose, that correlates highly with MRSA elsewhere on the skin surface. So when you're doing a podiatric surgery, that colonized person has a little bit more risk than the non-colonized person having a MRSA surgical site infection.
Is it like 10%, 100, 80%? Do you have does literature say like
The risk?
Yeah.
I'll have to, I can't quote you the exact number other than the studies showed that not knowing that MRSA was present increased the risk of having a MRSA surgical site infection.
I'll give you the reason why I'm asking the questions, because when I have patients, I have a hard time describing to them why they have to show up an hour early to get vancomycin, which, you know.
Yeah, it's a pain, but you shouldn't be seeing that much MRSA, because
No, it pops up every once in a while.
yeah, it's supposed to be 0.5% of the human population is colonized, so it's a pain, but hopefully it's not, you're not having to do it every day.
No, it's a couple times a year, but with those patients, I just have a hard time explaining to them why. And I think just telling them there's an increased risk, I think that's what I've told them in the past, but
I think it's real. I don't know if I can quantify the risk, but I've seen enough of it in my practice where I think what we'd be doing to prevent this, and then within the past 5 years, there's been a lot of push to prevent infections and elective surgeries. Many of the things we do already would help with that, the scrubbing of the skin and the total body cleaning. But there still were elective surgical infections occurring, so now we're layering in these other things to try to keep the risk as close to zero as possible. All right. I think there's one. So there's diverticulitis, where you've done the exam and the abdominal pain seems to fit well with diverticulitis, but there's not nausea or vomiting, so there's a reason to believe the person can take an oral antibiotic and have a successful outcome. These are a mixture of E. coli and anaerobic bacteria. So Augmentin XR is just perfect for that. Penicillin allergy that's Hives only, you have to combine an E. coli drug with a Bacteroides fragilis drug. So there's Keflex and Flagyl. If the penicillin allergy is anaphylaxis, where you can't use a cephalosporin, your E. coli drug becomes Bactrim, then B-Frag with Flagyl. And then lastly, sulfa allergy, I had to pull out the fluoroquinolone, but I'm always keeping that kind of low, specifically for the person. In that setting at the bottom there, they wouldn't be able to have a penicillin, cephalosporin, or sulfa, and so they're getting a levaquin Flagyl. It's not uncommon when I'm doing a hospital consult for someone that failed outpatient therapy. The initial antibiotic choice was levaquin and Flagyl without any allergies. So I'm just trying to point out you don't need those big guns that cause C. difficile right out of the chute. There's generally nothing to culture except if that person was going into the hospital, blood cultures are always good, and then the duration is 7 days. So diabetic foot, also you're looking at the patient, they don't have nausea or vomiting, they don't have high fever, there's nothing on the exam that suggests a limb-threatening infection. We're going to try to do outpatient therapy. Dr. Hudson's going to get involved with us too, and try to be sure that we've done the right things. These are always mixed infections, aerobic, anaerobic infections. So there's Augmentin XR again. And it's very similar, in fact, it looks almost identical to a diverticulum, except it's a foot. But it's just because the microbiology is similar. An E. coli drug, Keflex, and then something for B-Frag. Same things back from DS for the type of allergy. And then lastly is the fluoroquinolone. You'll notice, aside from this one that just happens to have Bactrim, the purpose of Bactrim there is for aerobic gram-negative rods, but there's not really as yet a general sense that every diabetic foot needs a MRSA drug. We would do that once they're cultured out. And the wound culture would be ideal if there's an open wound. Often there's a neuropathic ulcer that we can get a culture from. And the initial duration is 7 days. There with good follow-up to be sure that the infection is gone in 7 days.
Anything that would make you suspicious to worry about Pseudomonas early? Other than
just
like
past
green
history,
pus?
probably. That would get my attention if someone said this is the third or fourth one of these we had. There'd be a way to go back into Meditech or IC chart and see if Pseudomonas was consistent. Then that's a way of just sort of doing informed choices based on past.
What was that, Rick? I missed that.
What if, should we have diabetic foot Pseudomonas coverage every time? And I don't think so unless there was a past history of it. Based
Past history?
Yep, yep. Sometimes the microbiology, the foot infections, just repeat themselves until we realize that the nidus is actually osteomyelitis. And the surgeon and myself are working on that to bring it to an end. Thanks.
What would you use in place of the flagell if they're allergic? Because you have different.
Yeah, I don't see a lot of metronidazole allergy, but I know it exists. It'd have to be clindamycin. That would be the only other good oral choice there. Intravenously, there's a lot of different combination antibiotics that have anaerobic activity, but it would have to be clindamycin. Yep. So bite wounds, there's lots of those out there. Believe it or not, there's human bite wounds. You've probably seen a few of those. There's the fist to mouth injury, and then animal bites. These are also fairly mixed infections. They can have anaerobes, but they have great mixtures of aerobic organisms. So there's augmentin again for the no penicillin allergy. Hives only would be cefuroxime. And then a full penicillin allergy where there's no penicillins or cephalosporins can be used. Bactrim DS would cover the aerobic organisms, and then Flagyl anaerobic. And again, another example of how we just keep the fluoroquinolones almost as a last choice. We lose what's really happening around the country and locally. One of the drawbacks to overuse of fluoroquinolones is there's no longer any way to treat a Pseudomonas infection orally. Most of the Pseudomonas that we see anymore, fluoroquinolones are gone. Well, there was a patient that once they had a Pseudomonas UTI that could have been managed as an outpatient, but now they're fully resistant to fluoroquinolones and they're automatically hospitalized, even though they might not even have any other criteria that need to put them in the hospital. So think about saving the fluoroquinolones as best as possible. Culture of the womb is always good, and the duration is 7 days, but these two need good follow-up to be sure that at 7 days the infection is resolved. And that might be the end of that. With a few minutes left, I could take some questions. Another big part of your handout, we could do this another time if this is interesting, is empiric antibiotic choices for the patient that's going to be hospitalized. And they're all in the handout, little guidelines and how you read through that, what cultures to order. Those are loaded into the Benefice intranet. I'm not quite sure. Rachel, are they computerized for us, or is it's paper? I think.
There are lots of paper copies.
There's lots of paper. They're findable.
Everywhere.
Okay.
And then all the choices are like in the order group set, so.
Okay, all right.
But they're not in an on-ramp format.
Dr. Geyer,
Yep.
what are your thoughts on using antibiotics prophylactically? So I know like in Vision, we're doing away with the antibiotics,
The drops.
the drops, during the
You
injection.
told me about that.
Yeah. And, but as far as like in ortho, we do, before any dental procedures and how to go a total two-hour will be going off the floor, making sure that So same with in neurology, we do an also, if they have total joint, we do a cystoscopy in office.
It's not as, let's say, I'll say it the nice way rather than try to